Everybody, it's Dr. Eric Balcavage and Dr. Erica Riggleman. We're back for another edition of Thyroid Answers Podcast. And once again, we have another guest on the show. And I am really excited for today's guest, Dr. Erica, because little unknown story. I, at one point, was going to go to pharmacy school. That was one of the things that I wanted to be when I was a young little tot, was a pharmacist. But things changed, and now it almost sounds like sometimes I'm the anti-pharmacist, but I'm not anti-pharmacy. That's important to know. I think drugs have a place, especially in acute care. But I'm really excited to have on Dr. Kirsty Washam, who is the Fedup pharmacist. And so we welcome her onto the show, and welcome to the show. We're so happy to have you on. Thanks for joining us.
Thank you all for having me. I appreciate it. I'm excited.
So first things first, I mean, you're the Fedup pharmacist. I mean, there must be a backstory to why you are the Fedup pharmacist. So can you give us a little bit of background on you, how you came up with the moniker, the Fedup pharmacist, and then we can start just giving you all the questions that we're dying to ask.
Absolutely. So the Fedup pharmacist, it seems to have kind of a negative connotation, but it comes from a good place. So kind of my story is I'm a pharmacist. Okay. That's the Fedup pharmacist. But shortly after graduating from pharmacy school, I started having all these symptoms. Looking back, I had had thyroid symptoms for probably 15 years prior. I just didn't know what was going on. Okay. So I had my hair falling out, my eyebrows started thinning. I was stressed. I was anxious. I was depressed. And I just couldn't figure out what was going on. I had access as a pharmacist to some of the best physicians in my area. So I sought them out, and they just kept telling me, oh, you're just stressed. You're taking boards, you're moving across the country. And that was just the response I kept getting was, you're stressed. You need to drink a glass of wine, just calm down. My TSH, which was what I was taught in pharmacy school, was like the go-to thyroid test, right? So that was always normal. So I just thought, man, either I'm going crazy, there's nothing wrong with me, nobody can figure this out. One morning I woke up, and of course it didn't happen just that day, and I noticed this enlargement in my thyroid. And I thought, okay, something's up. I'm not going nuts. And so I finally found a physician who drew a comprehensive thyroid panel and found out that I had Hashimoto's. So at that point, I quickly realized I was on a benzodiazepine for my anxiety. I was on Celexa for depression. And I realized these were just little symptoms of what was really going on in my body. And so I realized that my Western medical training didn't have any answers for my autoimmune condition. And so I did what I was trained to do, and I started researching. And that's when it just occurred to me that food and diet and stress reduction, these were all things that I wasn't really taught anything about, but these held the answers to truly healing myself and then so many others around me that were going through the same thing. And that's where the Fedup pharmacist was born. I was just truly fed up with really not having any answers for what so many people were going through. And so at that point in time, I was a retail pharmacist, and I kept seeing patients come in month after month, and I'm filling these prescriptions for them, and like, they're literally not getting any better, right? So if anything, the next month they get a new prescription, and the month after that they get something new. And now I understand why that was happening, but I just became so discouraged by that I thought, I need to get out there, I need to educate myself, and I really need to help others realize what these root causes of these conditions are so that they can start to truly heal instead of just putting this prescription bandage on this huge issue that they have.
I think that's awesome. So you've transitioned out of the retail pharmacy. So where are you at right now with pharmacy?
With pharmacy, I still work full time, but it's in a clinical inpatient setting. So it's acute care. And I still see, modern medicine is phenomenal, and I am by no means anti-medicine. If you are hit by a bus on the side of the road, or if you have some horrible infection, modern medicine works miracles every day, and I see it. But for chronic diseases like diabetes or hypertension or autoimmune conditions, we need to dig a little bit deeper, instead of just doing prescription after prescription, just it becomes this vicious cycle that I see patients get on. And we'll talk a little bit more, I think, about that later on. Some of the questions have to do with something that I wasn't really taught in pharmacy school called drug-induced nutrient depletions, which is kind of this cycle that we see patients getting into, why you need one prescription to offset the side effects of another.
Yeah, so one of the things that we talk about quite a bit on the podcast is that we oftentimes look at what we see in our patients' symptoms or the signs as the problem. We see somebody with high cholesterol, we think the cholesterol is the problem. We just have to
Yes.
what we call whack-a-mole medicine, right? We just knock it back into range. We see high blood pressure. We think of the high blood pressure as the problem. We see hypothyroidism, we think of hypothyroid and the gland's the problem.
Yes.
And as long as we can kind of whack-a-mole things back into the range, then we've done our job. And we say that it's not really the doctor's fault per se. It's not the pharmacist's fault per se. That's what the model is. And it's the model, not the physicians. Your doctors, your pharmacists, they're good people. They're doing what they've actually been taught to do. The problem is the model is great for acute care. As you were saying, if I'm bleeding out, give me something, right? Like right now,
Absolutely.
I'm dying and bleeding, I want something right now, but that's a patch model. It's not a fixed model. And somewhere along the line, medicine kind of shifted, I think, from a fixed model, right, to a lifestyle medication model. We can argue, and I don't think we would argue about why, right? That's a very successful financial windfall for big business, but it doesn't help the patient, and that's the real issue. So I got a ton of questions, so I'll just start kind of digging into those things. And maybe the first one is, and I think you already answered that, is if you look at it from look at hypothyroidism from essentially the same perspective kind of that we do. We kind of look at thyroid physiology and hypothyroidism more as in many times as a protective mechanism. Some type of stressor or trigger is putting stress on the cellular system, and part of the process is to down-regulate metabolism, to protect the person and address the threat. You would agree with that process, that thought process?
I absolutely would, and part of my discovery and all of this was really when I was diagnosed with Hashimoto's, I struggled with accepting, because what you're taught in traditional medicine about autoimmunity is that your body is attacking itself. So I'm like, what is wrong with my body? Why is it attacking me? And really when my mindset began to shift was when I realized, your body is way too smart for that. Like if you go back and start looking at the basic science, your body's way too smart. It's not attacking itself. It's protecting you from something. And so in my case, and in the case of many others, it happens to be Epstein-Barr virus, which I had some advanced testing and figured that out. But our bodies are protecting us. They love us. They want to protect us. And so that's absolutely, it's just an innate and intelligent response.
Yeah. So that is one of the kind of foundational principles that we kind of think about, whether it's just having the hypothyroid symptoms, seeing the autoimmunity, or if they are in full out glandular hypothyroidism, we're always trying to normalize a TSH value. And as you found out probably through your own health and what you see in other people's health, oftentimes we can normalize lab values, but there's a cost to that, right? And we'll talk about nutrient depletion and the creation of other symptoms. So with your pharmacy background, where in the pharmacy education, is there any education that prepares you for looking at thyroid physiology or any of the physiology from a more functional perspective? Or is it really that the pharmacists get the disease-based model and here's how the drug works? We're not really worried about all the other ramifications. Can you give us a little background?
Sure. So no, I mean, my education is strictly the latter. So we were not focused at all on a functional component. I mean, you're in pharmacy school, right, to learn about drugs. And we learn these things in isolation. So you're never taught that when I take a pill for cholesterol, that it could affect a system outside of that. Does that make sense? So like your brain, or you're not taught when you take a proton pump inhibitor because you have acid reflux that could affect, again, your brain or your bones. So these like downstream kind of things don't really ever come into play. And it's not anybody's fault in particular. It's just that you have a limited amount of time and you're there to learn, the drugs. It's kind of a pill for every ill type model. That's what you're there for. And so when people go to their when they listen to your podcast and they start realizing all these different things and they go to their pharmacist or they go to their physician, understand that these people were not taught to think this way. It's not that they're not intelligent or that they don't want to help you. It's just strictly, it's a different frame of thought than what they were taught in school.
Yeah, the mindset, the dogma is all different. And that's right. And I think that's an important point that we want to make sure we get across is that, if you go to a pharmacist who's classically trained, right, not somebody who's kind of changed their thought process and philosophy like you, or you go to a medical doctor who's classically trained and you say, okay, the model that you're doing isn't making me feel better, do something different. They don't have do something different because that's all they know, right?
Yes.
So I think that's a key thing. As far as the pharmacist in the classic role, what can be or is your responsibility in the classic role, right? We'll talk about your new role.
Put that hat on. Okay.
Right. So in the classic role, you have people coming in to get prescriptions filled. You have doctors calling in and ordering prescriptions. Do you have, as a pharmacist in that role, any flexibility, allowability, responsibility to educate the patient based on what the medication is going to do and the things to look for? Do you have is there a sense that, or I don't want to say allowability is the right word, but to talk to the doc and say, hey doc, by the way, if you provide that prescription, that it may have certain implications on their health, or it may disrupt their thyroid physiology. Is there any role for the pharmacist in that?
Absolutely. And that's going to vary from person to person as far as their level of comfort with that. But as pharmacists, we are kind of the first line healthcare professionals. I mean, what other doctoral level professional can you literally just walk into any big box store and talk to for free? I mean, it doesn't happen, right? You don't have to make an appointment to see us. We're just kind of there and accessible. So absolutely, the number one role of the pharmacist, I would say, is education when it comes to prescriptions, is, informing the patient of side effects to look for, things to look out for, how to appropriately take their medicine. Education is critical. And even my role as like a functional type pharmacist, that's something that kind of carried over from my traditional training. But I mean, I would absolutely, depends on the physician too, if you kind of want to bark up that tree, but some physicians are, especially the newer ones. Okay. So as the medical model has kind of changed, people are starting to realize that there's a place for all of us within this like big healthcare puzzle, that not one single professional can do it all. So between nurses and chiropractors and pharmacists, like I feel like this interdisciplinary thing is starting to really happen. But yeah, so some physicians, especially newer ones, are really receptive to input from like what a pharmacist has to say about a certain prescription. And I've had great conversations with docs about things like that.
I think that's great that because I've seen where patients maybe got put on a medication and maybe a doctor didn't know that they were on another medication that was contraindicated. And, when you go to the pharmacy, they can look at your history and say, oh, no, you can't be on these maybe together. And so you kind of are that line where you can catch it before they actually get that prescription filled. But I'm sure that there are probably a lot of doctors out there who have their blinders on, who don't want to be open to somebody making a recommendation about, a medication or that avenue. So do you get, with your new functional role that you're, pushing and kind of out there advocating for, do you get a lot of pushback from other medical doctors, in that community, or even other pharmacists that, look at what you're doing as, not the role that you should be playing?
Right. So really, I kind of just kind of live my life. Okay. So I choose to live by example. I am not going out and like knocking Coca-Cola or candy bars out of anybody's hands. I'm not pointing my finger or criticizing, but I'm just kind of living my life as this example. And really amongst my peers, it's really piqued their interest because we're all struggling with different health conditions and different things, whether people admit it or not. I mean, it's just the fact of the matter is that we're increasingly unhealthy. And so people start to realize like, oh, well, if I change this about the way I eat, will this happen? And so they just started using me as kind of like a little resource. And I just kind of live in that way. I'm not out there just,
That's good, because I know a lot of people who push the boundaries of their profession, get criticized. And, some people, most people in your shoes probably would have stepped back and said, I'm just going to stick to my role. I'm not going to, push that boundary or even be an advocate for looking for, the root cause, the functional side of it. So I think that's great that you're out there pushing, your boundaries of your profession. I know both of us being chiropractors, we are naturally in the holistic realm, but still there's chiropractors out there who think that you should only be focused on the spine and not worried about promoting health. And so again, it's going back to that boundary of, I think it's great that you're open to it, and that you actually, with your traditional training, that you actually had the mindset to think that way. I think that's amazing.
I had a mentor early on that really opened my eyes to what I could be. Like, I never thought a pharmacist could be in this kind of functional realm. And so I was fortunate early on to have been mentored by somebody who had already kind of stepped out and paved the way. And so I'm just kind of following, in her footsteps. She's already blazed a trail here locally. But as far as like the hospital where I work at, I'll just give you an example. I had a good friend who comes from a family of physicians, surgeons and pediatricians, different things like that. And she had struggled chronically with just a bunch of different health conditions. And over the course of a couple of years, worked at the hospital. Y'all, she gave up gluten and dairy, and her health conditions, this is not the case for everybody. I don't want to say that food's a panacea for everything, but it's a great place to start. But these health conditions she has struggled with forever just went away. And so just by living an example, it's amazing what just living our lives and doing what we do, it's just a light for others. So
absolutely.
Yeah. So we know that we're definitely, you made a great point that we're increasingly unhealthy, right? We consume somewhere around 65 to 70% of the world's pharmaceuticals in this country. And we are probably in the top, probably consistently within the top 5 most unhealthy countries in the world. So it's not like we can drug ourselves healthy, right? So it does come down to diet.
It hasn't worked so far, right?
No, and I don't think it's going to change sometime soon. And so I don't see necessarily that, pharmaceutical education is not going to go away. The whole model is probably not going to change, but we are probably seeing some changes when it comes to thyroid physiology in terms of medication. And maybe you could touch on those things maybe just a little bit. The standard for years has been like Synthroid, levothyroxine, the T4 medications. Then we started seeing more of the natural products like the Armors, right? Things like that. And then what we typically see, and you may as well, is when people don't do well on T4 medication, right? Because the central regulating system, essentially think brain, right? And the peripheral regulating system, think body, kind of regulate differently under stress conditions. So the brain can really adapt to really quickly small amounts of T4, and the rest of the tissue can starve. But then we see people saying, oh, maybe now we need to just flood the body with T3. So we see that process going. We see trends towards, getting away from the gluten, maybe components of Synthroid and levothyroxine to maybe tyrosine. And now we're actually starting to see more of a trend by some pharmacists towards the compounding aspect. What's your take on the medications, T4, T3, the more natural products, and then now the shift or the move to compounding? Are you seeing that as well?
Yes. So with the majority of my patients are still on some form, brand, whatever, of levothyroxine. Okay. That's just the gold standard. That's what endocrinologists, that's what they're taught to use. And so that's what they're comfortable with. I have not seen these patients do well. Generally speaking, the patients that are on levothyroxine only tend to not see, in my experience, just any alleviation of their symptoms. So then they usually get put on, like what you're saying, like a Cytomel, some type of like T3. But I feel like the best response that I've seen are more like your biological base. So your WP thyroid, your Armours that have it's a biologic ratios of T4, T3, even T2 and T1.
Right.
Yeah. But with shortages, there have been some issues here recently with access to those. There's been a little shortage of some different brands that I've seen kind of a push to compounding. And I think there's a place for that. I love compounding pharmacy. It's essentially personalized medicine, which it can't get any better than that. Your doctor's able to figure out what exactly you need and what ratios, and the compounding pharmacist can essentially make that for you.
And they can make a ratio that's maybe a little closer when they're doing the compounding to the human ratio than what's maybe an Armour, which is more of a porcine version of thyroid hormone, because their values of T4, T3 ratio are a little bit different than what the human version T4, T3 is, right?
Right. I mean, we're not pigs, so
I think that the ratios are great. Sometimes people need to be on thyroid hormone, especially if they have had their thyroid eradicated or removed, maybe because of cancer. But I think that there's kind of what we preach in the whole podcast too, in our practices, is that you have to be asking the question of, well, why do you have thyroid issues in the first place? Going back to that functional part of it, is that, yes, that may band-aid your symptoms by taking, whether it be a bioidentical type or you're taking a synthetic type. But again, if you don't get to that root cause, there's probably going to be something downstream that you're just going to produce another symptom, and then need another pill to be able to combat that. And you get into that kind of vicious cycle where, again, you're adding pills every single month, trying to just chase the symptoms.
Absolutely. And we see that, so often. I mean, how many thyroid patients do you see that still don't have alleviation of like anxiety symptoms or depression? And so you still are, like you said, chasing your tail in essence. So healing those root causes, I mean, we're never going to be able to step away from that. You can't out supplement or out medicate issues within your body that you need to physically heal.
Right. And I think the key point is that and I'll repeat it for our listeners, I think we're all on the same page, is that what's really triggering your hypothyroid symptoms, it's not about what the gland's making per se. It's not about what's in the bloodstream. It's actually what's getting to inside the cell and into what they call the nuclear receptor of your cell. So if you're taking T4 and TSH or T4 and you're normalizing your TSH, the brain is reacting, essentially what they call the central regulating system. We'll just call it the brain, and the body react totally differently under stress conditions. So the brain has a totally different regulating system, takes very small amounts of T4 to really get the brain kind of re-regulated. And that's, from my perspective, and I think Dr. Erica will agree with me, that's by design, right? If I'm under fight or flight stress response, I need my brain to work, to function, so I can run and get away. And so I don't want much in the way of T4 being converted to T3. I want that to happen really quickly, really easily. But in the peripheral tissues, where I don't need some of those primary functions in fight or flight, I do want to be able to deactivate thyroid hormone. And those cells really do control what happens, for the most part, to thyroid hormone once it reaches there. So you can have T4 and say, my values are normal, but I still don't feel well, because it's what's happening at the cellular level inside the cells. That thyroid hormone can be and we're making this super simple, but it can be either activated to T3 or deactivated. And that's typically not being looked at by a general medical practitioner or an endocrinologist. No,
it's not. Absolutely not.
So the next thing I want to kind of get into is, especially with your background, there's a lot of drugs and medications that people wind up taking because they have what we call cellular hypothyroidism. So I'll walk you down our path. Well, kind of that way you can kind of understand where I'm coming from. We really look at hypothyroidism starting at the cellular level. And when thyroid hormone gets shut down in the peripheral cells, then we see things like insulin resistance, we see cholesterol start to rise. And those are the things that I call a multi-system adaptive response, right? The things we think of as disease or disorder, diabetes, hypercholesterolemia, high blood pressure, depression, those are the sequelae, if you will, of the deactivation of thyroid hormone. So then we put people on medications for the effect, right? Not the cause. And so what would you say are maybe 3 or 4 of the top medications that you've seen that directly impede thyroid physiology or shift thyroid values, especially TSH, because that's the primary regulator of thyroid physiology, you know, in the medical model?
Right.
Are there some medications that you see that go, yeah, this person's TSH is going to be compromised because of the medication they're taking? Is there things that you see?
There are. So a couple things that come to mind just right offhand are glucocorticoids. So these are drugs like people use for inflammation. So like hydrocortisone, dexamethasone, things like that. And there are dose-dependent issues there with those. So dexamethasone doses greater than like 0.5 milligrams a day, hydrocortisone at 100 milligrams a day or more. And these tend to decrease TSH. But these are drugs, you know, if you have a thyroid condition and you have inflammation in your body, these are things that you might be taking already. So just need to be kind of cognizant of that. The other thing is metformin. So something that people take for, I mean, it's literally the most common drug for diabetes that there is out there, for type 2 diabetes, let's be specific. But another one that decreases TSH.
So
go ahead.
One of the big ones I see is some of the drugs within the blood pressure medication family, like losartan can definitely have an impact in causing a lowering of TSH. We see some of the calcium channel blockers actually inhibit calcium moving into the thyroid gland, which then without the calcium in the thyroid gland, you can't make T4, T3. So there's a number of these medications. I've got probably a list of 12 of them, but I'm sure as you go through your daily activity, like in that model, you can start to see that this person's complaining of chronic hypothyroid symptoms. Their doctor may be saying, hey, you don't have a thyroid problem because your TSH is normal. That's the only thing that's getting measured. And yet when you, as the pharmacist, look at the medications they're saying, you're going, hey doc, they probably are struggling. Do you see these 3
Right.
you got them on? It's plummeting their TSH. They probably can't make T4, T3. We probably should look at the rest of the panel. Does that happen at all?
You know, it has, like, you know, as I've gotten into the functional medicine side of things, but let's just be clear that I was not taught any of this in pharmacy school.
Right.
So literally, I think the only drug thyroid thing that I was taught in pharmacy school that I can recall would be the link between like thyroid disease and amiodarone. That's kind of like a huge one that sticks out in my mind. But beyond that, people need to be aware that your pharmacist wasn't taught this. Your physician wasn't taught this. This is stuff that we have to learn on our own, you know, outside of our traditional educational model.
Mm-hmm.
Yeah, maybe that's your new role.
Maybe.
To re-educate the pharmaceutical world for those who are interested on the new way to look at pharmacy. I mean, that may be.
Sounds like a good one. I like that.
That may be your new podcast, right there.
Yeah.
So I think that's really important, because one of the things you said, which is kind of ironic, when we see cellular hypothyroidism, we have that deactivation of thyroid hormone in the cell. You can't, then your glucose transporters don't work, right? And so now it's harder to transport glucose into the cell. You actually become insulin resistant. You have to increase insulin to force it into separate transporters. And then you wind up being diagnosed as insulin resistance or pre-diabetic. You get metformin, which then suppresses thyroid hormone, which then further complicates the problem, creating it. So now the patient winds up in a vicious cycle saying, I can't lose weight. My hair is falling out. My skin is dry. I'm putting on belly fat. What's going on? And their doctor's saying, hey,
you're good.
You're good.
You're good, or just exercise more.
Yeah, exercise more, and they're, and you have these, I find it in women, especially, you have these women who are like, my gosh, I go to the gym, for an hour a day. I eat virtually nothing and I still can't seem to manage this. Well, it's not your fault. It's what you want to say. It's literally not your fault. There's something physiologically going on and we need to address that.
Mm-hmm.
Right. And so the physiology is to some degree altered, compromised, adaptive. And one of the big things I think that you hinted to, and we'll kind of talk about a little bit more here, is there's some type of stress response. And that a lot of that is coming from diet, lifestyle, medications, a lot of the stuff that goes on. So we'll talk about that a bit more. But I want to kind of add to what we talked about. There's drugs that directly can impact thyroid physiology. We talked about a couple of them, the glucocorticoids, metformin, blood pressure medications. But a number of the medications can indirectly impact thyroid physiology by kind of what Susie Cohen would say would be like mugging cofactors, right?
Yes.
So is there some drug medications that you see people taking that really tops of the list of the muggers of cofactors? And what's the biggest one you see mugged?
What's the biggest one I see mugged? Okay, so let's just talk about drugs that the Fedup pharmacist hates. Okay,
yeah.
These are drugs that, they just make the top of my list. Okay, so they would be proton pump inhibitors. So these are like the purple pills that you see advertised on TV. Your omeprazole. Can we say brand names? I don't know.
You can do anything you want.
You can do anything we want. Okay, so Prilosec, Nexium, things like that. Those purple pills. What else do I do? Oh, birth control. Oh my gosh, I could go on forever about synthetic hormones and oral contraceptives and the issues there.
I think a lot of people's thyroid issues are initiated or more exaggerated once they go on birth control, or they may not even realize that they had a thyroid problem or thyroid physiology problem until they went on birth control. And that was that kind of the straw that breaks the camel's back type of thing, that they start to produce all of these symptoms. I've seen it over and over with a lot of my patients with birth control.
And not to make it all about my story, but I feel like I've talked to so many women and they can kind of relate, is that I was on birth control for 15 years. And it really was when I came off of it that these symptoms all of a sudden really manifested. Well, they were there all along. They were just being suppressed by these synthetic hormones that I was taking. And, the thing about birth control pills is that it totally disrupts your gut health. There's no way around that. Your gut and your liver, which has long-lasting implications for total body inflammation and ultimately thyroid disease. We all have this chain, right? So, and we all have a weak link, and mine just happened to be my thyroid. Other people's might end up with multiple sclerosis or, other autoimmune type conditions. But if we keep abusing our bodies, we're going to break somewhere.
Mm-hmm.
Yeah. And I think that's one of the key things, especially that we can tie in, both Eric and I have looked at the genetic aspect of things. And right now that's like hot and sexy. Everybody's talking about, I have this gene SNP. I have this gene SNP. And the genes and the SNPs, maybe not the bigger issue. It's really the epigenetics, the things that influence those genes, has probably the much bigger influence on things. But definitely when we see people who are struggling with chronic health issues, whatever's driving the kind of that stress response is going to impact everybody's physiology a little bit differently. So you could still have 10 people under the same or similar stress responses respond and have 10 different disorders or diseases, or they may express differently because of other factors: diet, lifestyle, epigenetics, and genetics. So I think one of the things is we look at the genes too often and go, oh, well, I have that gene, so I'm going to get this. No. You're more likely to have problems down that pathway if the right things are occur. But it doesn't mean just because you have a gene SNP that that's the way things are going to happen, right?
Right. So, I heard somebody say this once before. So it's like genetics loads the gun, but your environment pulls the trigger. Yeah. And so, that could be anything in your environment. That could be stress. That could be the food that you're eating. That could be toxins within your environment. There's so many factors to address when you really start thinking about it.
Mm-hmm. Right. And that's, I think, the other issue that we have to discuss in in the difference between the allopathic model and the medical model, or allopathic model and the functional model, is that, you know, in the functional model, the goal is to diagnose primary hypothyroidism. So once the diagnosis is done, the treatment's the same, right? We just try and normalize values. There's not a lot of effort put into what's triggering it, what's causing hypothyroidism, whether it's autoimmune or not autoimmune. It's not a significant concern. There's no real concern as to the stressors, maybe lifestyle factors that really drove it. It's really just about normalizing TSH and T4. But in the functional model, that becomes really, really important, because you could have 10 people in a room and they all developed hypothyroidism for 10 different reasons, right? And so that's the challenge. Is in the medical model, there's not time to assess and sit down with somebody and say, let's try and figure this out. The model is really based on quick visit. What do we got? Here's what you need. Out the door. Normalized. Good. Right?
Yeah.
Right.
I think that the customization is really important, not only for functional medicine, but for, you know, traditional medicine to try to customize that and again, look at the root cause of it. We often see patients, if you've got symptom A, you're going to get drug B. It's protocol. And again, that's how they're trained. But even in functional medicine, I'm seeing a little bit of a shift with patients coming to see me that have already seen functional medicine doctors, that you've got symptom A, you're going to get supplement B. It's just shifting. It's the same kind of protocol. It's just shifting between a medication and a supplement too. But again, it has to be customized for each person, because we're all different when it comes to our disease processes and what's contributing to our issues versus somebody else.
Absolutely. You know, there are certainly places to begin, but until we break this mentality that I can take X supplement or X drug and it's going to make me better, until we can break that mindset, so that we as individuals are going to have to put the work in. Mm-hmm. That seeing your physician, I mean, what's the average physician's visit? Probably like 10-15 minutes, and you see them twice a year. You know, miracles are not going to happen in 20 minutes of a year. I mean, they don't have time. A physician does not have time this day and age to really sit down with you and address these issues. I mean, if you go in saying I have acid reflux, they don't have time to figure out why. They're not going to sit down and think, well, oh, you have low thyroid function. Maybe you have low stomach acid. Well, that's not the mindset. The mindset is, well, I'm going to write you this prescription, get you out the door, and you're going to feel better. But what issues is that going to create long term?
Mm-hmm.
Right. And so they're not, you know, most medical doctors aren't trained from a systems approach, right? They're taught very kind of mechanistically about, hey, if you have a reflux, that's a stomach issue, and so we'll fix the stomach issue. But for you, for me, for Dr. Erica, there are conditions that when you see them, you go, oh, that's probably somebody who has hypothyroidism, whether it's primary glandular hypothyroidism or cellular hypothyroidism, which is what we think is by far the number one type of hypothyroidism, is really what's happening at the cellular level. And that primary hypothyroidism is probably is the end stage, not the beginning stage. But is there, if you think about it as you see labs, and you already kind of hinted to it, like hypothyroid or hypochlorhydria, low stomach acid, right? Mm-hmm. They have reflux. Does that make you think hypothyroid for that person? Not the classical primary hypothyroidism per se, but that there's some type of cellular hypothyroidism going on?
Absolutely. Absolutely. And, you know, it's widespread. I mean, pretty much every patient that I see is taking something for what they've been told is too much stomach acid, which in all reality, if you dig down into the symptoms, is probably too little. And so once you start telling them, you know, you can't absorb your nutrients without stomach acid, that gastric barrier is really the first line of defense in your body for infection. I mean, that's what keeps bad stuff out. It's just the stomach acid. It kills the bad bugs. So you start seeing people getting, you know, C. diff infections, and now we're linking also Alzheimer's and osteoporosis and a lot of really scary conditions to use of these proton pump inhibitor type drugs. And looking back, they were not designed to be used long term. Mm-hmm. So that's the key, is that these drugs, when back in the day, when you went to the pharmacy, when they first came out over the counter, you could only buy a 14-day supply. So that should have told us something, that, you know, we were never intended to shut this mechanism down long term, or there were going to be repercussions.
The other thing is, there aren't studies done on the combination of drugs either. You know, they may do a study that somebody 15 years later that was on this statin was perfectly fine, but did they also consider their diabetic medication, their thyroid medication, their proton pump inhibitor, their blood thinner, like all of these combined? I mean, where's the studies that show that that's safe when you combine all those chemicals together, that those aren't compounding the effects, the negative effects on people's health?
Absolutely. So that's something, it actually has a term. It's called polypharmacy. And y'all, it is not uncommon. So I have worked in pharmacy since I was 16 years old. My first job was at just a local pharmacy. And you would give people maybe a couple prescriptions, you know, a month, and they would come in and get them. You put them in your cute little pharmacy bag and send them out the door. It is nothing for me this day and time. Now, keep in mind that I practice in the South, and I practice in a rural area. And Kentucky is always at the top of the list of the most obese states. So we're very unhealthy, high rates of diabetes, lots of smoking. This is the tobacco growing region. So lots of smokers. It is nothing for me to dispense upwards of 30 prescriptions a month to a single patient.
Wow.
And you can't fit that. I mean, literally, I'm sending out, when I worked in retail, I would send out people's prescriptions in boxes, cardboard boxes, because they were on so many drugs. And so absolutely not. I mean, there's no way of knowing what that is doing. I mean, you're on prescriptions to offset side effects of other prescriptions. So it's just a pill for every ill, back to that same thing. And you're just caught in this vicious cycle. And I mean, people die that way. I mean, it's a full-time job, literally taking handfuls of pills a day.
Yeah.
Now, in your background, are you encouraging patients to look at other ways, other means? Obviously, you probably don't have the ability to take people off the medications that are prescribed, but recommending that, you know, maybe ask your doctor about looking into this for you, or, you know, maybe looking at a natural way to manage that. I mean, I get a lot of people who want to not be on statins. What's the natural way to help with my blood, you know, my cholesterol levels or my blood pressure? They want natural ways. So do you get people coming to you asking for natural ways to help manage those issues?
Absolutely. And so my favorite is just clean up what you eat. You start eating real food, a lot of this stuff will start going away. And again, you know, it's not a cure-all, but if we start decreasing sugar, if we stop, you know, consuming processed foods, we just get back to whole, real foods, that works miracles in and of itself. I mean, Hippocrates said, let food be thy medicine and medicine be thy food. And that was 2,000 years ago. It's the same guy who said all disease begins in the gut. And we are really just now, 2,000 years later, starting to see how right this mindset was.
Right. And I think the challenge is that what we're asking people to do, even though it's a simple thing, right?
It's hard.
It's not easy, right? Especially when you grew up in a lifestyle where you ate these things and this was the norm, and now you're telling somebody to go back to eating real food versus this simple, cheap, inexpensive, processed food. And I think you're dead on. I mean, there's so many diets that are going around, and a lot of them have some merit to some degree, you know, keto, paleo, all these things.
Right.
I think we spend way too much time fighting, even within this model. It's like we've circled the wagons and we're shooting in. Well, vegan's better than paleo, and paleo's better than keto, and keto's better than carnivore. And, you know, and we're missing the point. And I think what you said is really the key. And that is, listen, stop worrying about everything else and just start eating real food. And the reality is, for some people, then they put the block up. Well, I can't afford organic food, so I can't do it at all. No.
Right.
Start eating real food first. Eat real food before you start freaking out about whether you should be keto, paleo, carnivore, anything else. Just start getting in the habit of eating more real whole food. Even if you did that and it's not organic, you would probably be better off. Would you agree?
I would 110% agree with that. Yes. I mean, I've had several patients that I've worked with on a one-on-one basis who just by eating just real healthy food, I mean, they've been able to go off of cholesterol medicine, off blood pressure medicine. That's even happened in my own family. So my mom had what they said was a familial hypercholesterolemia, which miraculously disappeared after 30 days of a real food diet. And this is not the diet that the American Heart Association would say is appropriate for someone with high cholesterol. So this is not your low fat, high grain type diet. She was eating eggs and she was eating meat. I mean, this is all real food. But she was able to go off cholesterol medicine that she had taken for the last 20 years, despite that heart healthy diet that she had been on with all the oatmeal and the low fat yogurts and everything didn't work. And my dad was the same way. I mean, years and years of high blood pressure, and we take out the junk and we add in some real food, and all of a sudden he's lost 20 pounds and his blood pressure is normal. And this is not restricting sodium. This is not doing a lot of the things that the traditional medical model would teach you that you need to do.
And even though it's familial, they didn't have to leave your family, right? They did this still within the same family.
Yeah, within the same family.
Yeah.
Isn't that the dangest thing? So I heard somebody say once that diabetes doesn't run in your family, the Paula Deen cookbook does.
Yeah.
Y'all, I mean, how true? I mean, not to be, but that's true. I mean, look, your family's eating hot dogs and whatever else. I mean, of course, you're all going to have diabetes.
Right. I tell people it's not in their genes, GENES, right? It's in their genes, JENS, right?
I like that.
It is, it is because we typically have the same habits that our parents had and our family has, and we all eat the same, and we drink the same, and we smoke the same, and we do the same kind of lifestyle. And so, look around your 5 or 6 closest friends, right? If the 5 or 6 people you spend the most time with, you probably look like them in many times because you eat like them, you drink like them, you socialize, and you behave like them. So yeah, it's more habitual than it is familial.
Yes.
Or genetic, I should say.
Or genetic, right? Yeah.
So great point. So let's do this. There's more we could ask, but I want to respect your time, right? And one of those things I want to make sure we do is, now that you've kind of stepped into this kind of functional world, and I give you tons of credit for still staying in the model, even though
it's hard.
Yeah, I'm sure it would be a battle every day, but that's probably where you have your niche to really make some change based specifically from the doctors, that maybe help educate a doctor a little bit with a little nuance, right? Because you're in there with them. Maybe help the patient with a little bit too, because you're in the environment with them. But what would you say, like if we had to ask, what are the 3 big things that you really try and get the people that you're working with to change? And we already talked about food, and I just have to say this before I go a little bit further. If you're in the hospital setting, one of the number one worst things, you already know where I'm going with this.
Yes.
Is what we serve sick people in a hospital setting, right?
It blows my mind. Okay, so again, when I go on the floor, so I'll go on the floor from time to time to do patient education on particularly like anticoagulants. So these are cardiac patients. I mean, they're getting blood thinner medications, right? And so I'll go up there and say, it's lunchtime, they have their meal tray. It's like fried chicken tenders and French fries and some kind of like red number 40 Jell-O with a Diet Coke. And it's all I can do to not just knock the tray off the table and be like, here, please eat this. No, it's horrible. It really is. You're at your weakest point most of the time when you're in the hospital. I mean, you're there for a reason, right? You're super sick, or you wouldn't be there otherwise. And you're getting the worst quality food imaginable. Yeah. And I know it's all because of money, right? I mean, this all goes back to the bottom line. But it really is, it's horrible. And I've been in conversation with some of the people that work within food service at my facility. And I know they think I'm crazy, but I'm like, y'all, you're feeding people food that, like especially chicken and meat and things, that is loaded with antibiotics. Well, that's just contributing to antibiotic resistance. Mm-hmm. So, I'm doing my best. I'm kind of blooming where I'm planted and trying to inform and educate to the best of my ability there within my facility. So yes, back to your question. So yes, food I think is absolutely number one. If people would just quit worrying about whether to be vegan or keto or paleo or what have you, and just not eat food that comes out of a box or a wrapper, that's a great place to begin. Another place, number two, I would say, is stress reduction. Stress is going to kill us, whether it's financial or work or home. We can't live in a bubble, but we've got to find ways to manage our stress. Meditation, prayer, running, exercise, like whatever it is that works for you, I encourage people to do that. And the other thing is if you can get off these medications, especially these drug muggers like we were talking about earlier, these proton pump inhibitors and birth control and things like that, find a pharmacist, find a physician, find somebody to help you de-escalate your medication therapy. Don't do it on your own. Like, don't just say, I listened to this pharmacist on this podcast and she told me to stop taking my drugs, because it's not what I said. There's an appropriate way to get off of, antidepressants and benzodiazepines. Those are really, really tough, and you're going to need somebody to help guide you through that.
Absolutely. Don't
just stop your blood pressure medicine cold turkey. But as you begin to get healthier, you're going to see less and less need for these prescriptions. And hopefully you can start coming off of some.
Yeah. And I think those are really good pieces of advice, because unfortunately sometimes I see it in my practice, Dr. Erica probably sees it in hers, you start to educate people on what some of these medications can do, cause problems, and then they go, okay, I'm done. I stopped them all. Whoa. Your blood pressure is like, you're not healthy enough to stop this stuff. We just want to let you know that they're not fixing anything. And now we've got to go through a process, right? That what we do is we start fixing some of these things that they can do: diet, nutrition, lifestyle, sleep patterns, breathing habits, fix the gut, address blood sugar regulation. And what the person's going to see is that their blood pressure slowly and steadily starts working itself back to normal. And then from normal, they're going to start to get into where it gets too low. And that's where they need to have been tracking it, keeping a record of it, so they can walk into their doctor with, hey, here's my last 30 days or 60 days of my first morning blood pressure. And you can see the trend. Right. And now I'm at, 100 over 50 and I don't feel good. And now they can make a really educated decision to say, okay, we're going to reduce the dose, versus if somebody just goes in and says, I don't feel good, my blood pressure's too low, they're going to be like, okay, well, we got to monitor this thing, find out what's going on here, because they're not aware of what they've been doing, right?
Right. I mean, there's a smart and responsible way to do this. And I think that is a great role. I mean, myself as a pharmacist and you all as, healthcare professionals, that we help patients do this responsibly. Mm-hmm. We can't just, and like you said earlier, I mean, medication it's not the devil. If you have high blood pressure and you need to be on medication, please do, or you're going to have a stroke. But until we can address those underlying causes.
Right. The great Band-Aids, we just don't want you, and some patients, it's okay. I think it's important to understand too, there are some patients and people that do not want to put work into trying to fix their underlying causes. And if that's your choice, then prescriptions are the solution for you, right?
Yes.
Because that will keep you alive. It's not going to necessarily make you healthy, but it'll keep you alive longer. But if you are a person who's gotten to a point where you're frustrated, you really do need to understand that there is a, as you were saying, there's a way to do this appropriately so you don't harm yourself coming off your medications, and you've got to get yourself in a healthier state so that there's an actual need to come off many of these medications, because the prescription you were given was based on you being significantly less healthy. And now that you're more healthy, many of the doses that you're getting are probably inappropriate. Would you agree with that as well?
I would. And what I'm so excited to see is really that patients are starting to realize this. You know, there is an increasing awareness of, you know, man, I've been on this prescription for, you know, so many years and I'm not feeling any better. What can I do? And so people are really starting, you know, I think maybe just access to social media and different books being out there. I always encourage people to educate themselves and to really become their own physician, so to speak. I mean, knowledge is power. And when they go into their doctor's office, they need to be armed, you know, with this information.
Mm-hmm.
Absolutely. All right. Well, I'll tell you what, we could probably talk for another hour or two if you have time, but we all have things to do. So what I want to do is I want to thank you so much for coming on the podcast. We really appreciate it. We will have to look to get you back on here sometime in the future and kind of finish this conversation a little bit.
Yes.
And,
yes.
Can you give the listeners, just if they want to get more information about you and, you know, and what you do and a little bit more information from a pharmaceutical standpoint and functional medicine, where can they find your information? I'll put it in the show notes, but why don't you let them know how it's best to get a hold of you?
You all can find me, typically I'm most active on Instagram or Facebook, and you can find me there at the Fedup Pharmacist. So.
Awesome. All right, Dr. Erica, any final questions?
No, I think that what you're doing is great. I will tell you that we give seminars in our area, health seminars, and a lot of times I'll have pharmacists come up to me, and when they tell me they're a pharmacist, sometimes I'm like, oh, they're all about medication. And again, I'm not anti-medication, but a lot of them are really open to this stuff. They want to learn about the natural stuff that's out there. They have that open mind. They see the frustration. They're in it. They're kind of stuck in this middle ground where they're stuck in between the patient and the physician, and they see it and they're looking for other options. And I just think it's great what you're doing.
Well, I appreciate that. Thank you so much. And anytime we can spread the word and help people get better, that's what this is all about, right?
Absolutely.
Absolutely. All right. So we'll wrap this one up. Thank you so much for coming on, Dr. Erica. I will see you in, I think next week, we got to do film another podcast. And for anybody who's got any questions regarding anything you heard on the podcast, wherever you see, listen, or watch the podcast, just add your comment. And if you're bored, go to iTunes, give us a nice recommendation on iTunes. That's always good and helpful. And let your friends and family know that we're out there and we're trying to do as much as we can to help other people who are struggling with hypothyroid symptoms get the answers they are looking for. All right, so let's sign off. You guys have a great day, all right?
Yeah.
Thank you.
Take care.
Bye.